Managing obesity is tricky. This is something that has often been going sort of creeping on for many, many years. If you think about it, if people have just an extra 100 calories a day, or sort of do a little bit less exercise, which results in 100 calories extra that day, and that could be as little as a biscuit or a couple of biscuits. If you do that every day, at the end of a year, you probably put on maybe 1 kilogram, maybe two, which is about 4 or 5 pounds. Um, if you do that for 10 years, that could be 10 kilograms. That could be about a stone and a half. And of course, if you do it over 20 years, you can imagine that the weight will creep up slowly. So it is very challenging to change that when the weight has been there for a long time. And I think that's what we found very, very difficult in the obesity field. We have now got a few options with drug treatments, but before we didn't have very many effective treatments. So I think lifestyle changes are very important in type 2 diabetes. If done very early after the diagnosis, in some people, and people have heard of this, you can actually reverse type 2 diabetes. That can be a little bit drastic. It's quite an extreme diet. But if people can do that for, well, it's often a couple of months, then they may well put their diabetes into remission for 3, 4 years sometimes, or need minimum medication. So that's something we do explore with people. Otherwise, I think in general, the lifestyle changes that people make in type 2 diabetes are actually the same advice as we give to everyone for their general health. So it is moderation, it is trying to keep essentially fat and carbohydrate levels at sensible sort of levels, trying to get in a good 150 minutes of a sort of moderate exercise a week. So it's nothing sort of particularly unique. They're generally sort of general health advice, really. Diet and nutrition are both very important in obesity management, but I think it should be recognized that it is very difficult to lose significant amounts of weight with diet alone. It depends a little bit on how long the weight has been coming on over. So if the weight has been gradually coming on a couple of kilos every year for the last 10 or 20 years, it can be very, very difficult um, to reverse that with diet alone, because the body has a metabolic memory and it will instantly try and take you back to the weight that you were at, or quite often a slightly higher weight, because it perceives that you're in a starvation mode. So if the weight has come on very quickly over a year or two, that's a little bit different. But if it's been going for a long time, then dietary measures are often not successful. And if you look at the studies, and these are controlled clinical trials with nutritionists and health coaches, etc. And most of the time, people were only able to lose about 5% of their body weight, sometimes 10%, but not very much more than that. And I think that's really worth keeping in mind when you look at someone's body weight. So if someone is 100 kilograms, then you can have a realistic idea of how much body weight you could actually lose with dietary measures. Overall nutrition, of course, is very important, and when we even if we use the obesity medications, we do need to make sure that people are still getting a healthy, balanced diet. It's important that all the vitamins, etc., are present. So blood sugar monitoring, it depends a little bit on the type of diabetes. So for someone with type 1 diabetes, will need blood glucose monitoring several times a day. In the olden days, we used to use finger testing, and that would be often 4, 6 times a day. And we now use glucose sensors. So that would be the standard of care for people with type 1 diabetes. For type 2 diabetes, it's a little bit different. We do use glucose sensors in type 2 diabetes, and that can be useful to see what the glucose is doing. It can be useful to see how it responds to certain meals or to exercise. But in type 2 diabetes, it probably is not needed all the time. So what we have found is that if actually people put a glucose sensor on for a couple of weeks, maybe once every 6 months, maybe once a year, and they, in a way, check in with their diabetes and see how they respond to certain meals, how they respond to a walk around the block. That's often very informative, and that is often enough. In between, people with type 2 diabetes can do some finger testing, and it can be useful to do a fasting glucose maybe a couple of times a week, but it's not essential, and it's more just to sort of inform you how things are going. Of course, much of type 2 diabetes, particularly in the United Kingdom, is managed by primary care colleagues and who do an excellent job, and of course is done very well. As specialists, we can probably add some extra value to that, where we can be very helpful if there are diagnostic conundrums, and there can be. So sometimes it may not be obvious if it's type 2 diabetes or type 1 diabetes. And in fact, I've got a special interest in trying to classify diabetes, and I've got an interest in some of the rarer causes of diabetes, such as genetic diabetes. So a specialist can add quite a lot of value to try and get to the bottom of the actual diagnosis, particularly if it's a little bit unusual. We've also been checking people's glucose control with a blood test called the HbA1c, and we pick up people with pre-diabetes a lot more than we ever used to, and sometimes that can pose quite a few questions, particularly if it's in someone who's slim or quite young. And again, the specialist can add quite a lot of extra value to that, because we see a lot of the rarer causes of diabetes, and I think that would be very helpful. We're also very experienced, of course, in overall management, and particularly the more complex management of diabetes. In type 1 diabetes, it's completely different. I think everyone would be in agreement that type 1 diabetes should entirely be under specialist care. In obesity, obviously lots of different people are involved in obesity, and of course primary care colleagues are invaluable here. I think where the specialists come handy are particularly probably in either in the use of these new medications, the weight loss medications, or in assessment for bariatric surgery. We have a lot of experience with particularly the weight loss medications. We have a little bit of a feel for who will do well, particularly, and also some of the problems that you can get, some of the things that we should look out for, where it could be perhaps unwise to use an obesity medication. And we've built up quite a lot of experience in these medications. So particularly at the beginning, when starting these medications, I think a specialist is very helpful. Sometimes people do need quite a bespoke plan when it comes to the obesity medications. So we often work towards a particular target, and we work with people. But then after that, what do we do? Do we stop the medication? Do we think about a maintenance sort of dose? And I think the specialists again are quite good at that, because we've got sort of ways of perhaps reducing the dose down to a maintenance dose. And we've got quite a lot of experience with seeing how these things go long term. And of course, we're generally very up to date with the latest obesity management drugs, and they are coming out thick and fast at the moment. And we may have sort of tablet forms of some of these medications as well, which might be cheaper and easier to take long term.